Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health finance and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about deep brain stimulation, a new procedure being used to treat Parkinson's disease, dystonia, and essential tremors. We'll be talking with Dr. Roger Smith and Dr. Georgia Lee. In the second half of our program, we'll be taking your questions live by phone at 504-866-3200 and by email. Just email your questions to us at hhquestions@wlae.com. Tonight on the program, we welcome neurosurgeon Dr. Roger Smith. Dr. Smith earned his undergraduate degree from Stanford University before earning his medical degree at the University of Southern California. He completed a year of surgery at Tulane University and a neurosurgical residency at the Barrow Neurological Institute in Phoenix, Arizona. He also completed fellowships at the University of Zurich in Switzerland and the National Hospital in Queen Square, London. Dr. Smith has previously served as president of the Louisiana Neurosurgical Society, and the president of the Orleans and Louisiana Medical Societies. Dr. Smith specializes in surgery of the brain and spine and has been on staff with Ochsner since 2001. We're also pleased to welcome neurologist Dr. Georgia Lee back to the program tonight. She received her undergraduate degree at Kansas State University before earning her medical degree from Emory University School of Medicine in Atlanta. She completed her residency in neurology at the University of North Carolina at Chapel Hill before completing a fellowship in movement disorders here at the Ochsner Medical Foundation. Dr. Lee's been on staff with Ochsner since 2008 and currently serves as director of the Deep Brain Stimulation program. Joining our doctors tonight is the Chief Financial Officer of Ochsner's Health Systems Corporate Division, Scott Boudreau. He is to my right. As much as we'd love to talk about the great work that Scott does for Ochsner, he's actually here tonight to share with us his firsthand experience having undergone deep brain stimulation, the procedure we are discussing. And we welcome all of you to Hello Health. Good to have you with us on the program.
Thank you. Appreciate it.
And we look forward to hearing more of your story tonight, Scott. Well, Dr. Smith, let's begin tonight with a quick introduction of deep brain stimulation and its the brief history of this relatively new procedure.
Yes, thank you, Tom. A little background, the surgical treatment of Parkinson's disease actually goes back many years, back into the 30s, 40s, and 50s. And at that time, it was recognized that if some of the deep clusters of cells, which are called nuclei in the brain, were injured, that some of the Parkinson's symptoms, particularly tremor, would be relieved. There are ways to make small lesions with electrical currents and nitrogen, and this was a fairly common procedure done. But when
you're actually injuring the brain, right?
Actually injuring the brain,
right.
Making a small hole in the brain. This is can be quite specific. It's done with what's called stereotactic approach, using coordinates, and we'll go into that a little bit when we describe how we do the current treatment. When it was discovered that dopamine was the primary problem, the lack of this transmitter dopamine in the brain, medical treatment and the ability to deliver dopamine into the brain became available, and there was some loss of interest in surgical procedures. However, subsequent symptoms developing with the use of dopamine led to a resurgence of interest, again going back to making small injuries in the brain. This carried some danger and was irreversible. To his credit, Dr. Benabid, a French neurosurgeon, working with a neurologist, applied what was known about deep brain stimulation to these various areas of where it was found that if they were stimulated without injuring the brain, that the symptoms could be relieved. And that really opened up. This is really done in the early to mid 1990s and was approved by the FDA for approval only in 1997, so less than 20 years ago. The treatment has been exceedingly successful, and now many thousand cases have been done around the world. I think it is something that, as we discussed tonight, we'll find is exceedingly beneficial in the right circumstances for many patients.
All right, let's go off script for just a moment and just a little bit of background first. Parkinson's disease. What are some of the symptoms of Parkinson's disease, and how many people are impacted by it?
Over 1 million of people in the United States alone have Parkinson's disease, and they can come in several different subtypes. One type being the tremor type, which most people might be familiar with or think they're familiar with.
The shaking.
The shaking type. And another fairly common type is called the rigid type, where they might not have any tremor, but they get stiffness of one side of their body.
Okay, very good. And we'll be talking with Scott Boudreau, who had the stiffness type, and he'll be sharing his story in just a few moments. So, Dr. Smith, let's talk about the surgery and the main components that compromise deep brain stimulation. And you brought along some images. You're going to show us images and a video, too.
Yes, the general principle here is somewhat similar to pacemaking in cardiology, and that is that we want to deliver a train of small electrical impulses to a very specified area of the brain. It's still a little unclear whether that stimulation is blocking or is actually stimulating nerve cells, but at least the outcome of that is quite similar to results if the brain is injured, but as mentioned earlier, reversible and programmable. And so what we have, Tom, is first a wire, if you will, an electrode that is placed with careful coordinates down into a very specific part of the brain. That wire is then connected to heavier connecting leads that can pass under the skin of the neck.
I think we've got the video to show people as you're describing this. Go right ahead. Yeah.
And then finally connected to what we call pulse generator, or a pacemaker. This is a battery that allows many high frequency pulses to be delivered over several years, really. Before the battery needs to be changed. And here you see on this mannequin the pulse generator, the pacemaker, if you will, in place on the chest wall. This is just under the skin, not under the muscle. The connecting leads are coming up underneath the skin. Everything is fully implanted up behind the ear and then connected behind the ear to the electrode that was actually placed carefully in the brain during surgery. And you see there trying to describe how these pulses then are being transmitted into the brain. This is something that's under the control of the physicians and the patients. They can turn this off and turn it on, and the neurologist particularly can regulate how much current and how fast the current is delivered, which may be important to each individual patient.
Dr. Lee, you're in the surgery, I understand, there too. You're turning it on and you're deciding how much power to give it, and how is all of that regulated, and what role does the patient play in all of that? Either assuming the patient is asleep during the procedure?
The patient is awake during the procedure.
Is awake during the procedure. Okay.
Yeah, right, Scott?
Oh, definitely.
They're awake, and the purpose of that is because we need to be able to hear the brain cells firing with a recording device. If they're asleep, the cells will be asleep as well. And also we need to test that wire once we place it. So with the patient awake, we can turn it on, we can start programming it, and we can immediately see instant results in the OR.
Okay. Well, let's talk about some of the conditions that are treatable by DBS.
So essential tremor and Parkinson's disease are FDA approved and even covered by most insurance companies because they are standard, deep brain stimulation is standard of care. Dystonia is a separate disorder but also treatable by DBS.
And dystonia would be, quick explanation would be?
Dystonia is a permanent or constant contraction of a muscle group, typically of the neck in some people, but it might be of the foot or the hand, arm, or leg. And comes from maybe genetic causes, sometimes brain injuries, other things like that. Newer uses of deep brain stimulation include Tourette syndrome, obsessive compulsive disorder, chronic pain, and depression. Those are still all in experimental research.
Okay, and local basketball fans might remember Chris Jackson, who I think went on to take another name when he made it to the NBA, suffered from Tourette syndrome, so that may help people make the connection. And Dr. Smith talked about, you know, that we had this procedure and then we got away from that and moved to more pharmaceuticals. Does it always, are most patients usually going to start with drugs before you would take a look at this as a deep brain stimulation as an option?
Absolutely, because not all patients will need this surgery. A percentage, and perhaps a large percentage, will, simply because we're all living longer and having the disease longer. But certainly an ideal case would be somebody who only takes a 3-time-a-day pill for their entire life. We wouldn't have any consideration of brain surgery in that patient. Okay.
And in what cases does this make the most sense? At what point are you going to make this recommendation, as you did for Scott Boudreau?
So there are several indications for deep brain stimulation in the treatment of Parkinson's disease. One of them being a refractory tremor, so somebody who has a bad tremor that doesn't respond to medications. But for the rest of people with Parkinson's looking at deep brain stimulation, it comes down to the medications. Either the medications aren't lasting long enough, they're having side effects to them, or they're having what we call motor fluctuations or dyskinesias. They're up high 1 minute and then wearing off the next minute, and they're going through this roller coaster every day of their lives. They are also candidates for deep brain stimulation.
Okay, let's turn now to Scott Boudreau, who is here to share his story, a colleague of Dr. Smith and Dr. Lee, who got to know them in a whole nother light
That's for sure.
through all of this. So let's start with when you first noticed that you were having issues and how you learned, in fact, that it was Parkinson's disease.
Well, I noticed I was starting to shuffle, and I was playing some golf with some buddies of mine, and they asked me, "Why are you limping?" And I didn't think anything of it, and you know, you want to think you're invincible and everything, so I came up with some excuse that I didn't loosen up before the golf round and everything, but it started to bug me when they kept asking me about it, so I said, and my wife said, let's find out what the story is and what do you have. So I went to a neurologist, and I was diagnosed with Parkinson's, which is a very humbling disease, and I didn't know anything about it, and I learned a lot about it quickly, and it's an interesting disease. I had rigidity, which was an issue that I had with Parkinson's before the surgery, and you know, I'll talk about that a little later on.
Well, yeah, when we hear of people with Parkinson's, most of us think of people shaking. For you, it was the opposite, right?
Right, yes,
and
definitely.
how would you describe it to me?
Okay,
or to others
can you do this?
I can.
I couldn't do that.
Okay.
I couldn't do that. This is how my hand would move, and it was very exasperating. Another example is I couldn't put my shirts on, really. My wife had to pre-button my sleeves for me not to slip into my shirts because I was too rigid to get the shirt on. And the normal person probably could put a shirt on in 35, 40 seconds, and it would take me, one time I timed it, took me 8 minutes to put a shirt on. So it changes your lifestyle in regards to, you might have to get up an hour early than you normally do to adjust for this.
Now you said it started with a shuffle, and you were
the Boudreau shuffle.
Yeah, the Boudreau shuffle, and you're lying to your friends.
Right.
Were you lying to yourself?
Without question.
Did you know there was something more serious than a muscle pull or just getting older?
No, I didn't think it was getting older. I knew there was something wrong with it. I guess I didn't want to admit it. We all don't want to admit we're getting older, but it wasn't that getting older part of it. It was not being able to do certain things.
Mm-hmm. And how did was Dr. Lee able to talk to you? Because it wasn't a, hey, this sounds great, let's go do it tomorrow, right?
Oh no, it wasn't that easy. That's for sure.
Took some convincing.
She for about 5 years, she was after me to get this done. And you know, when you're talking about your brain, you're like, I don't want anybody messing with my brain.
You've only got one of them.
I've only got one of them, and it's probably, I went to East Jefferson High School, so I went to public school, so, but it's done me well. But she kept bugging me for 5 years. My daughters and my wife kept bugging me. One of my buddies, Jim Cole, used to send me videos of Parkinson's and deep brain stimulation. I kept telling her, give me the medicine, I don't want the surgery.
And were you using, just to back up, were you using the medicine, and what kind of impact was that having?
It was helping out, but she had to keep increasing the dosage. So she said, you're the perfect candidate for this. And it's funny, another physician friend of mine, Dr. Steve Jurisco, he did a colonoscopy on me last December, and we were talking about the surgery. He says, well, you had that done, you might as well have another surgery done. So, but I was in Baton Rouge at an event, and I saw me doing a Boudreaux shuffle in the mirror of a hotel, and I'm like, enough is enough. So I quit avoiding Dr. Leah when she was walking down the hall, and I told Dr. Leah, Dr. Smith, Dr. Houghton I was ready to have this surgery, and I'm glad I did.
Okay. And I'm not in any way trying to make light of any of this we're talking about tonight, but this is important to the story. 7 years ago, you were a pretty good golfer, right? And a pretty good bowler, too.
About 7 years ago I was, yes.
All right, even with the beginning of the Boudreaux shuffle.
But then we took a turn.
And then we took a turn. All right, and we'll talk about that towards the middle of the program. We'll share the rest of that story. Well, Dr. Lee, or Dr. Smith, rather, if you could, let's talk about the surgical procedure itself and the areas that you're targeting with this deep brain stimulation.
Sure. Well, maybe start with the areas, and I'll tell you how we arrived there, Tom. As mentioned earlier, the circuits that we're speaking of, and that's maybe the best way to look at it, the clusters of cells are called nuclei or ganglia, and this is the basal ganglia and a group of nuclei called the thalamus. These are deep down in the brain, down in the core of the brain, and hence the term deep brain stimulation. And so we have to have a way to get there. And the general targets, we use the term targets, meaning where do we want to put that electrode into the brain. And the targets we generally use, as you see, are the globus pallidus interna, which is one of the main basal ganglia circuits, the thalamus, which is the oldest target that we mentioned that used to have holes put in it to try to control tremor, and then more recently the subthalamic nucleus, which at one time was thought to cause severe pathology if injured, but actually has been the most valuable target for us for Parkinson's disease. Depends a lot on what the actual symptoms are, and patients that have primarily rigid or dystonic type of Parkinson's, we generally go with the globus pallidus, the old target, where more classic traditional tremor type Parkinson's, we're almost always using the subthalamic nucleus. So how are we going to get there? Well, what we need to do is to have a way to find that target in the brain, and that's done now much more conveniently than our predecessors with MRI and CT scan. Having these computer imaging studies remarkably hastens the ability to find what we need to do and to use coordinates. For many, many years, a halo, a ring vest was used to put the navigation equipment on and then measured out at one time by hand to try to find out just how far you had to go to get there. Again, the computers have made life much easier for us. So currently, we use a frameless stereo system, which is actually more convenient and more comfortable for the patients. The way that we initially set up is that the first day the patient comes in, and Scott will remember this well, we take them and put them under local anesthesia and put 5 little screws in the skull. Those then take the place of what would be the frame. That afternoon, we do a program with Dr. Lee and myself to figure out just how we're going to get there safely and not injure anything in the brain going down. The patient himself or herself on that Monday only has to really just rest up and get ready for the surgery. The following day, we go ahead, we put the patient under some anesthesia, but awake, because we need, as Dr. Lee said, cooperation. We want to know if there's any side effects, if this is working. We want to listen to the brain talking. So a small hole is drilled about the size of a dime, and through that a wire, the electrode we talked about, is slowly brought down with recording with Dr. Lee and our neurophysiologist, listening to brain cells, testing, and seeing what we're getting. When we're happy where we think we are, then we go ahead and actually stimulate that area. If the patient tells us something is not right, I'm not seeing good, I feel numb, I can't move, then we have to move the electrode to a different spot. All this is very, very close and very precise. But generally speaking, that's done fairly rapidly. And once we have that electrode in, we cap it in place and we bury it under the skin. To put the generator that you saw on the chest wall, you need to have general anesthesia for that. So we've been letting the patients go home after the electrode is placed, bringing them back 1 week later, and then putting them to sleep for about 30 minutes. And with that, we use a little tube and pull the wires down that you saw on the mannequin, hook them up to the generator. And at that point, we close and let the patient heal up. I usually take their sutures out about a week or so later. Then in a week or two after that, Dr. Lee or Dr. Houghton will see the patient in the clinic and begin to do the actual turning on and programming. And so we always have to warn the patients a little bit that you aren't turned on yet when you leave the hospital, that don't expect to be cured yet. But that's the overall procedure. It's been exceedingly well tolerated. There are methods for trying to do this with under anesthesia and so forth. I think that what we're doing is very, it works well, and we've been very satisfied with it, and I think that Dr. Lee and Scott will attest to our outcomes, that I think we're doing a good job with it.
The image you showed us was color-coded, all the different parts of the brain. My guess is that's not the case in real life.
No, unfortunately.
Yeah.
But of course, this is blind surgery, Tom. You don't really see the brain. All we see is a small hole. So we have to rely, like a plane taking off from an airport and landing at another airport, where we're going to start and where we're going to go. And that's that term stereotaxy or stereotactic, using coordinates in space to find where the electrode needs to end up in the brain. But it's all calculated, and that's why we have to, I think, listen to the cells and stimulate and be sure that we're just where we want to be before we stop.
And with all the advances in visual imagery, there's no way to, at the end when you're drilling in, to go in and for you to be able to look and see?
No, because...
And how, even if so, how helpful would it be? Or is this the reaction and the information you're getting from the patient, perhaps from Dr. Lee, who's looking at things, more helpful than even seeing
Yeah,
parts of the
that's
brain?
what's important. The wire going in initially to test is just a very, very fine wire, like a human hair going down. The actual DBS electrode is about 1 millimeter, like a piece of spaghetti capellini. And so we don't see the brain itself. All we really see is just the images of following down. And we are able to use the computer to actually follow, if you can imagine, just like looking at an airplane and following it through space, you can follow the image of the electrode tip as it goes down through the brain. So virtually, the way things are going these days, virtually you see where you are. But actually with your eyes you wouldn't be able to see that at all.
Okay, did they describe all this to you before the surgery?
Excuse me. They described a lot of it to me. Buddy of mine, Jim Cole, had sent me some videos on it, and you see it, but when you're having the procedure done, it's a different ball game. But they were right on with what the procedure was going to be like, and I was nervous during the procedure, I have to admit.
Yeah, you're awake?
You're awake during the procedure. Yeah, I thought I'd be asleep sometime, but I wasn't. I was awake during the whole time.
And they're drilling into your skull?
They're drilling it, he's scraping it, my skull's moving. I must have said the 23rd Psalm about 500 times. I was praying God gave them the talent there to come through and pull through. Halfway through the surgery, I told Dr. Lee, I said, I'm ready. She says, what do you mean? I said, I'm ready to go. I'm finished. She's like, we've got 2 more hours to go. I said, no, I'm serious, I'm ready. But she talked me through it, and thank you, both y'all, for taking care of me and talking me through it, because the results have been amazing.
And what kind of questions, kind of still in the surgery now, what kind of feedback are they asking for, and what kind of feedback are you able to give them?
Well, one of the things I did mention.
And how is that helpful?
I used to carry my hand like this, and I heard them talking to each other, move it this way, move it that way, and all of a sudden my hand fell. Dr. Lee said that they found a sweet spot. And it was amazing, because I started crying on the table there. Even though I wanted to get up 25 minutes earlier. It was just amazing. And then they ask you to move your hand, do this, do that, and so they can see that it's working. But when my hand opened up and fell, it was wonderful.
Is there any, when you're going in blind, is there any danger of, you hit the sweet spot, which in this case was a good thing. Is there a chance, and I'm sure you probably talk about all this on the front end too, is there a chance you hit a spot you're not supposed to hit, and is there a chance of permanent damage, and what are you doing to reduce those risks if they exist?
I think there's always a risk of damage that would be primarily if bleeding occurred along the track of the electrode. But we move very slowly, we're very careful, but when we pre-plan in the way that I described to you, we can see virtually where we are going to go, and we make every precaution to stay away from veins, from arteries, from the spinal fluid systems. When we get to where we think we want to be, we have a fair knowledge of anatomy, Tom, so if we get effects that we don't expect, there's too much tingling, the patient's eyes are crossing, he's having trouble speaking, we have a pretty fair idea where we need to go from there to make that move. I will have to say that the coordinates, the target, is sort of standardized, and yet humans aren't standardized.
Yeah, every brain's
so
probably
every
a little
brain's
different
a
in
little
size.
tiny bit different. That little tiny bit is very important.
Right.
So that sometimes we have to take the electrode out and put it back in, maybe just 2 millimeters away, but that can make all the difference. And so that's pretty much how Scott was reacting.
So Dr. Lee's holding his hand literally and walking him through. What information are you gathering from Dr. Lee? What is it important that information she's providing you, Dr. Lee or Dr. Smith?
So like Dr. Smith said, we are looking for the reactions to our stimulation. And if we do get something like tingling, then we discuss between Dr. Smith and the neurophysiologist, Dr. Wayand, and I discuss, okay, what does this mean? Are we too far left? Are we too far right? And we move accordingly. And we make, on average, 2 or 3 passes with the microelectrode, meaning that our first shot we might not be happy with, so we make another pass until we like what we hear, and then we test the electrode.
So really as a team, and we talk about this often on this program with Ochsner, it's a real team approach. In this case, the patient's part of the team.
Big part of the team.
Absolutely.
And an important part of the team. So Dr. Lee, talk to us about how people are impacted, some results of this surgery that you have seen with your patients.
So the indication for the surgery we discussed earlier about motor fluctuations, medications not quite working. The effects of stimulating or using that deep brain stimulator is to control a tremor or reduce the rigidity, and also to reduce the medication requirement, especially over time.
So there may be medication needed even after surgery.
There is absolutely medication needed after surgery. It is not a cure. People often feel like they're cured for, when we turn it on, and that's wonderful. But the disease does still progress, and we need the medications because of that, but also because the DBS does wonderful things for the physical symptoms, but there are some other what are called non-motor symptoms of Parkinson's disease which it does not address. We still need medications for those.
Okay, and it's funny or not so funny that the same procedure can help with tremors, people who are moving too much, and people who can't move at all. And talk to me about, because I'm sure there'll be people watching tonight, is this something that ALS patients, and ALS has certainly got a lot of exposure recently, especially here in New Orleans with Steve Gleason's case. Is this procedure something that could be helpful with ALS patients?
Unfortunately, I don't think, Tom, that that's something that, that this technology is applicable to. ALS is a degenerative disease of the nerve cells themselves, and some of the circuits that apply to the movement of nerve cells, but they mainly affects the so-called motor neurons, the cells in the spinal cord and brainstem that make our muscles move. And this is a different problem. The movement disorders that we address that have been successfully treated with the deep brain stimulation are those where circuits have gone awry, and if we can interpose ourselves somehow into those circuits and try to help correct them, the symptoms will be improved. With ALS, unfortunately, the nerve cells themselves are dying, and the ability to stimulate part of the nervous system has not proved to be helpful in that case. Maybe Georgia has some additional
You said
thoughts.
you get the question often from patients or people interested, and you compare it to what, a computer, right?
Mm-hmm. So the deep brain, the basal ganglia are the cells in the deep brain. I think of it kind of like a computer. They work at times, but they also freeze up at times and don't go. And the deep brain stimulator can actually encourage that or keep it moving. Whereas something like ALS, I liken to losing power. You're not going to be changing the circuits. You're not going to be jump-starting your computer. You're really losing power.
Mm-hmm. Let's talk about essential tremors, Dr. Smith, and how DBS would help with essential tremors.
Yeah, tremor was really the symptom of Parkinson's disease that first caught the attention of neurosurgeons back in the era that we spoke about. Essential tremor is a little bit poorly understood, but very common issue, and it does tend to have a hereditary, or at least a familial relationship, and so often somebody with tremor will say that they have a brother or sister or their parents exhibited tremor. Slowly progressive over many years, generally involving the upper extremities and the head, but sometimes more. This is in a way the ideal DBS treatment because the only problem is tremor. Mm-hmm. And if you can control the tremor, then the patient is back somewhat to normal for age, whereas Dr. Lee mentioned there's many components to a Parkinson syndrome, and tremor, rigidity, dyskinesia are only part of them. So I think that a lot of our essential tremor patients have been some of our most satisfied because the primary symptom is quite accessible. We do use a little different target. We talked about where to put the electrode tip. And we actually have pretty much gone back to what was done in the 1930s and 40s, and that's is to put that in the thalamus, another set of nuclei in the brain, close, but not actually at the areas for Parkinson. And stimulation there is quite effective in managing tremor. And so I think that the actual pathology of tremor is unclear. The fact that it's familial probably suggests there's some genetic tendency to it. Often a glass of wine or a minor tranquilizer will reduce tremor in patients like that. And so there's something to do with the activity of the nervous system that brings this tremor out. But at least it's been a very satisfying disease process for us to address with the deep brain stimulating system.
All right. Well, we brought along some videos tonight to show our viewers, and these are different symptoms and different parts of the disease being treated in different ways. So you're going to see kind of, I think that's on one side before and on the other side after. So we'll take one of them at a time, and go ahead, feel free, Dr. Smith, Dr. Lee, to kind of walk us through these if we would. Let's take a look at the first one now.
This is a Parkinson patient with primarily tremor on her left. Without the DBS on the left and with the DBS turned on, basically stimulating her brain on the right, controlling her tremor.
I've always been surprised that you turn the patient's stimulator off, 5 years later, that tremor will come back in 5 minutes. And you turn the stimulator back on, and it's gone again. I'm still shocked by that. It's incredible that works.
And these are patient control, which is why they can do that. They turn it on and off. Is the switch, you said it's under the skin, is it remotely controlled?
Magnetic, yes.
Okay.
Something like turning your TV on and off.
Right. Yeah.
The access device has to be touching them. So it's not like their spouse can sit across the room and turn them on and off.
Right. Okay. And the battery on is all the battery up? Here we go, another patient. Take a look.
Yeah, this patient we believe has essential tremor based on the videos, but on the left without DBS turned on, and on the right with his DBS turned on, brushing his teeth.
And really not able to brush his teeth.
Correct.
They're on the left side of your screen. And I think did we have one more video to show? Here we go.
Yeah, I think this is another woman with Parkinson's disease, tremor are predominant on the left, and her with the DBS turned on, showing how well her tremor is controlled. And I think it's sort of unfair. It gives everyone the bias that we only treat tremor, but as you can see, the videos are much more compelling when you can see this big shaky tremor stop. But just as much good is done for rigid type Parkinson's.
Sorry, Scott, you didn't make the video. But the story is just certainly as compelling, and we're going to get to the end of it in just a moment. So there's a battery on the outside with the remote, I guess, just like with my television. Is there a battery on the inside, and how do you replace that?
Yes, the battery is built into the generator system. It's not a separate piece. It can't be removed and put back in the generator. The whole generator needs to be replaced because it's all sealed to keep body fluids out. But generally speaking, with normal use, the generator battery will last about 3 to 5 years, and it's fairly easy to replace. The patient just comes in as an outpatient. We can do this under local anesthesia, open the incision over the chest, take the old battery out, hook it back to the same wires that are already placed there, close the incision, the patient goes home, and check the wound in 2 or 3 weeks. And so that's fairly easily done. And
with the exception of posing for video, which these patients did, is there ever a reason to turn it off?
Yeah, it can occasionally interfere with an EKG. That's a heart test. Not by disrupting anything in the heart, but just by the read of the EKG. So a patient might turn it off for that. Certain procedures also, dermatologic procedures, might require them to turn off their DBS as well.
Okay.
Often movement disorders are quiet at night, and so the question is, for battery life, should they be off and on or not? And those are the kind of things that Dr. Lee discusses with the patient when they're in the clinic.
Okay, very good. Well, we want to invite you to call us with your questions right now about deep brain stimulation and Parkinson's disease and tremors. You can call us at our phone number, 504-866-3200. That's 866-3200. Or you can send us questions by email at hhquestions@wlae.com. Now, Dr. Lee, we also wanted to talk to you about some age limits for this type of surgery, and you felt that that was important. We discussed that tonight.
There is no age limit. There is a health criteria. So a healthy 80-year-old can undergo DBS. A healthy 90-year-old could undergo DBS. But somebody maybe in their 60s with heart disease and diabetes, they might have some medical indications that might limit their or raise their risk of any kind of surgery, quite frankly. So there is no age limit. The criteria are similar to what I mentioned before about having the symptoms that you need, you know, uncontrolled tremor, or high medication doses or side effects to medications before you proceed with being a DBS candidate.
And obviously there are great benefits, and we saw those benefits in some of the videos. Scott, for you, how has it, obviously you now have less rigidity in your hand. Do you have any rigidity in your hands anymore?
No.
Is the Boudreaux Shuffle still around?
Boudreaux Shuffle is a thing of the past.
Thing of the past.
It is.
So how has it impacted, well, let's start with the simple things. Your golf game and your bowling, and you've got some specifics, right?
I do. I used to golf in the low 80s or high 70s. I'd sneak in the 70s sometimes, but in the last 7 years I had trouble breaking 110. I went the other day and I shot a 92. It's my second time since the surgery. Of course, my buddy Michael Sprague's gonna ask for strokes now, but he's not getting anything. And in bowling, I used to bowl 170 to 200, and I had trouble breaking 100. I went a couple weeks ago and I was back in the 170s. Another thing that I'm excited about, there's two things I'm excited about. First, my medicines have been cut in about half, so that's wonderful there.
And how often are you taking, what are you taking and how often?
Mirapex once a day, and Azelette once a day, and what's the one that starts with a C?
Carbidopa?
Carbidopa, a couple times a day. I was at a men's retreat a couple weeks ago, and they had a little function in regards to like an athletic event, a mini triathlon, but when I say mini, a real mini, there's not a lot involved. But, so we're forming up teams, and this is after the surgery. Normally, I would have, in the last 7 years, would have just snuck in the back and not asked to be on a team. But one of the functions was running about a half mile. So I said, I'll be on one of the teams to run. So we came through as a relay. We were in second place, so I'm running, and a buddy of mine's gaining ground on me, catching up, so I started sprinting, and I fell. And I cut both my knees, and I had a cut over my eyes. You know what the great thing about it was? That I fell, because I wouldn't be able to do it. I want everybody who's a candidate for this procedure to have it done, because it changes your life. And a lot of things you enjoyed doing, I can do again. I'll give you another example. Do you like to go to Ruth's?
Yeah.
What do you get when you go there?
Sizzling steak.
For the last 7 years, you know what I've gotten? Appetizers.
Cream spinach?
Not quite that one. The crab meat and some of the other ones.
Not that easy, yeah.
But and the reason I got it because I couldn't cut a steak. Now my wife and my daughters, my friends would cut it for me, but maybe my ego was in the way or something, but I didn't want to do it. But last time I went, guess what I got? A couple of months ago. I got me a steak, thanks to these wonderful folks and the God-given talent that they have. And I want to thank you all again. And I stress, anybody who is a candidate for this surgery, please have it. You get your life back. A couple months ago, my grandson, his shoes were untied. I bent over and tied his shoes. My wife says, "Do you know what you just did?" I said, "What?" I said, "I tied his shoes." She says, "You can tie your own shoes 4 months ago." It's just changed my life. It's gotten 7 years back. I've gone back in time, and I'm just so blessed.
Well, we're very happy that you came tonight to share your story and to answer questions that some of our viewers might have about your own situation.
And it does, the surgery, like I said, does take about 4 or 5 hours, and halfway through I want it out. But the more I think about it, have you taken a trip from New York to LA?
I've been to both places, but never cross country.
By the time you fly from New York to LA, you can have the procedure done. And in your plane, you can't stop in the plane and get out either. So get the surgery.
All right, we're going to take a break. The time to call with your questions is right now. 504-866-3200, 504-866-3200, or you can send us questions by email, hhquestions@wlae.com. You're watching Hello Health on LAE. Back with your questions in just a moment.
You're watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
We can beat this. The spill in the Gulf, it's a catastrophe.
But we will solve it.
This is not a Gulf Coast issue.
This is a national problem that requires a national solution.
But what can you do to help?
What do you have to offer? Your voice.
Speak up.
Add your name to the petition
Demanding restoration and protection
of America's Gulf Coast.
Sign it.
Share it.
Be the one.
Be the one. RestoreTheGulf.com.
And welcome back to Hello Health on WLAE. Tonight we're talking about deep brain stimulation, an amazing new treatment option available to people suffering from Parkinson's disease, dystonia and essential tremors. Our guests, Dr. Roger Smith, Dr. Georgia Lee, and Chief Financial Officer Scott Boudreau of the Ochsner Health System. But that's really not what he's here to talk about tonight. He's here to talk about his own story and his own surgery with this new treatment option. And now your questions. Let's go to line 2. Susie is calling us from Metairie this evening. Susie, welcome to Hello Health.
And thank you. I'm 79. I live in Metairie. And I just have one question. Is there a connection between Parkinson's and Alzheimer's and dementia?
Let's turn to our two doctors. Dr. Smith?
Probably a better question for Dr. Lee. Some Parkinson patients do develop cognitive difficulties, meaning memory and organizational thinking processes. A little unclear, is that a primary symptom of Parkinson's, or is it superimposed Alzheimer's disease, if you will, since the age groups are often together? There are syndromes around the world where dementia, if you will, so forgetfulness and memory problems are coordinated with Parkinson-like symptoms. But in general, Susie, I think that those are considered to be two separate diseases, and I'll let Dr. Georgia Lee speak.
About 40% of people with Parkinson's disease will get a dementia, typically a Parkinson's disease dementia, slightly different from Alzheimer's. And then those patients with Alzheimer's disease, a small percentage of them in their severe state will have Parkinsonism or Parkinsonian signs.
Okay, but two different diseases.
But two different diseases.
Okay, thank you for the question, Susie. Let's go back to our phone lines. Jim calling us from New Orleans this evening. Jim, you're on Hello Health.
Hey, less of a question, more of a comment. I also am a patient of Dr. Lee, and Dr. Smith performed the surgical procedure on me, both sides, actually. I had tremor, and it's fortunately gone now.
Very good. And your story similar to Scott's tonight? Any differences we should know about?
I didn't have the stiffness. Mine was more tremor. And it took me a while to get up the courage to do it. And then it took me another year and a half to do the other side. Because that's a pretty wild experience when you're wide awake and they're drilling through your skull.
I still can't imagine. I can imagine it because I've heard it tonight, but it would be tough to make that decision. But and how have the results been for you?
The results have been excellent. The tremor's virtually gone. I sometimes forget to take my medicine. I shouldn't tell the doctor that, but it works so well.
That's terrific. Well, Jim,
Please,
thank you for calling to share your story. Now, Jim talked about he did one side and then went to the others. I'm assuming that's an option, right?
Yeah, we typically like to stage them. In other words, one side first and then give it a couple of months and then the second side. That's for people who have both sides involved. As you saw from some of the sample videos, they were really one-sided problems or tremors. So we might only have to do one side in certain people. Scott, we did both sides the same day because we knew he'd get scared halfway through. Right, Scott?
And because he knew the right people at
That's right. That's right.
You knew you wouldn't get him back in, right?
That's exactly right.
All right. And you're glad you did both?
Oh, praise God. I'm definitely glad. Thank you for talking me into it again.
Most of the studies have shown benefit with both sides. But if you have a patient who's somewhat older, more fragile, or has medical issues, it is taxing, as you've heard from Scott and Jim, to have surgery done. And we just feel it's a little safer to get one side done, let that heal up, make sure that we're getting the result we hope we want to get, and then bring the patient back and do the second side.
All right. Let's go back to our phone lines. Line 5, Charles is next, calling us from Marrero this evening. Charles, you're on Hello Health.
I'm next.
Charles, go right ahead. Charles, are you there? Okay, we're going to take a break. We're going to go to our next call. Charles, we'll ask you to call us back or we'll put you back on hold. If you're watching on television, we'll ask you just to hold on to the phone and turn the sound down on your television in case there's a delay, and it sounds like that was the case with Charles. Let's go to line 6. Ashley next, calling us all the way from Bush this evening on the North Shore. Ashley, welcome to Hello Health.
Hi, I'm actually Scott's daughter.
Hi, baby.
I just wanted to call and say that we love you, Daddy, and we're so proud of you. And we wanted to thank your doctors for giving you your genuine smile back. It's been amazing, amazing what the surgery has done for you and for our family, and we just wanted to thank them.
Thank you, sweetie.
Thank you, Ashley.
We love you.
Dr. Lee, hold on, Ashley. Dr. Lee.
No, I just wanted to take your call a minute to thank also Dr. David Houghton and Nisha Shabria, both physicians here at Ochsner until Nisha left recently, who also have been an integral part in Scott's journey.
That's true.
I might just also, Ashley, say that it shows that something like Parkinson's chronic disease does not only affect the patient, it involves the whole family. Everybody is involved, and when the patient is made better, the whole family is improved. And so I'm glad you called and said that.
And Ashley, before you leave, on a very serious matter, can you vouch for the golf game?
I did not see it, but he's not a liar, so I believe him.
All right. Sounds like he's a competitor.
He's a competitor.
Maybe we'll get to play golf out of this. Maybe I'll come back and report to everyone about his golf game. Maybe we'll get to play golf out of all this together. Ashley, thank you so much for calling. Very, very nice. Let's go to line 1. Neil is next, calling us from Uptown. Neil, welcome to Hello Health. Neil, are you there? Looks like we may have lost Neil. Let's go to line 3. Mary is next, calling from New Orleans. Mary, you're next. Mary, go right ahead. Oh, I'm sorry. Neil, are you with us?
Yeah, this is Neil.
Okay, Neil, go right ahead. Sorry.
Good evening, everybody. I'm a Parkinson victim, and I'm curious about how long do the effects of the surgery last, and what are the potential problems?
Good questions, Neil. Thank you.
The benefit has been very durable, Neil, meaning it's gone for years. While we've only been doing this about 8 years, as I mentioned, this goes back almost 20 years, and patients still show benefit from that. That said, this is a progressive disease, as Dr. Lee mentioned, and so symptoms can worsen despite the benefit that's being derived, but the benefit stays with you. We always think about risks when we do any type of surgical procedure. The most common would be bleeding, because you're putting something in the brain that's been exceedingly low but not zero. Infection sometimes occurs because this is a foreign body in your body, and infections can occur. And then sometimes just breakage or discontinuity of the system itself. It is a mechanical device. Overall, it's quite safe, but no one should ever go into any surgical procedure without being advised of potential complications and risks.
And when you say years, so if Scott had asked you going into the surgery, okay, how long is this going to last? You would say the evidence shows us what?
Forever, as far as we know. And as I mentioned a little earlier, I just still remain so impressed that patients that have had an electrode in 15 years, you turn it off, the tremor will come right back. And you turn it back on, the tremor goes right back away. Years.
And Dr. Lee, you wanted to say something as well there.
Yeah, we have data now out 20 years with patients both with tremors and rigid type as well. And it's true, if you turn off the machine, you get effects back. And then even further out, 30 years has been shown it's still effective. The hardware is going to be good as long as you keep replacing the battery, but we're talking about, the progression of the disease still happens. The DBS is still contributing something all the way to the end.
All right. Let's go back to our phone lines. I believe Mary is next now, calling us on line 3. Mary, welcome to Hello Health. Good evening.
Yes, I was interested in knowing where this procedure was developed or who discovered it, from where, and also how were these doctors trained to do this procedure? How were they trained to do it, and where did this evolve from? A medical school or what?
Good questions. Thank you, Mary.
That's my question.
Thank you, Mary.
Deep brain stimulation has been used for various treatments, but the application to movement disorder and Parkinson's disease was really championed by Dr. Benabid in Grenoble, France, and his associate, his neurology associate. That couple of doctors actually earned the Lasker Award this year, which is the sort of Nobel Prize for Innovation in Medicine in the United States. It spread fairly quickly because surgeons were familiar with the technology. It was just the application of it. So yes, most medical schools that have departments of neurosurgery do have neurosurgeons that are specifically interested in what we call functional neurosurgery, where devices are used to try to correct brain disorders. And in the state, although we have the largest experience, there are several other neurosurgeons that are doing deep brain stimulation and doing a good job with it.
Dr. Smith, I read your resume at the beginning, which took up about half of the program. I say that in jest. So how did you train specifically? That was the other part of our question. How are surgeons trained in this using the deep brain? For you, where were you trained?
Yes, the most common way at this point in time is taking a fellowship with a program that's at a university or at a hospital that does a lot of that. In fairness, ours was a little different. I want to give credit to Dr. Jayaraman Rao, who longtime neurologist at LSU and in New Orleans, and really was the guru of Parkinson's in South Louisiana, and Dr. Lee's mentor. And after the hurricane, he came over. LSU hospital, as you know, was down. came over to Oxnard and asked me to get involved with it. And to answer your question, we went to different universities where people were doing it and trained with them, and then brought that technology back here and have developed it over time here. So you do need to be in a location where this is being done, but a lot of it is now very computer and technology dependent, and to be honest, makes it a little easier than it was 30 years ago to do something these things. So I think it works very well.
Thank you for your questions, Mary. Let's go to some email questions now. Reading from the script, there has not been much discussion of using stem cells from any source for treatment. At one point in the past, this was the greatest hope for a cure for Parkinson's. Where does this treatment option stand for stem cells? Where are we? What's the latest today?
So stem cells in Parkinson's are still being researched, actively researched, but one problem is that we don't know what the cause of Parkinson's is, what is killing the cells that are there now. So simply replacing them with new cells is not the entire solution. Those cells will also get Parkinson's and die. We do have some experience in the 80s with transplanting fetal cells into brain for Parkinson's, for the treatment of Parkinson's disease. And while initially it looked very hopeful, the patients did well, those cells either started to die or the patients had uncontrollable, too much dopamine, too much movements, and even a couple died from tumors caused by those transplanted cells. So while there is still definitely a lot of research in stem cells for Parkinson's, it's not as close to the forefront as, say, maybe for diabetes or other things.
Okay, here's another email question. What is known in regards to heredity for Parkinson's? My paternal grandmother had Parkinson's, as well as my mother, who was diagnosed in her mid-50s. What are the chances of this email questioner developing Parkinson's?
So less than 10% of Parkinson's disease is caused by a genetic trait or a directly attributable genetic trait. So it is true some patients have entire families where the Parkinson's disease ran, but in general 90% of people with Parkinson's it was actually idiopathic or just came about for unclear reasons, not genetic.
Okay, we've got just a minute or so, minute and a half to wrap up, so I'll give each of you a couple of seconds to, what do you want your viewers, our viewers tonight, to know about Parkinson's? What do you hope they come away with about Parkinson's and about this particular procedure? Let's start with Dr. Smith, Dr. Lee, and then we'll head back over here to Scott.
Well, this is a difficult, chronic, debilitating disease that progresses slowly over many years. I think that the medical treatment of this syndrome, of this disease process, since 1960 has been almost magical, but it was found that it just wasn't permanent enough and that there were patients slipping through the cracks that needed different treatment. I'm pleased that we have a safe and effective treatment to offer for this. I think that it's something that the patients need to discuss in great detail with their neurologist, as we heard earlier tonight, as to whether that's appropriate for them. But I think it's something that can be extremely beneficial in the right cases.
Dr. Georgia Lee.
I want to emphasize that it is not a cure for Parkinson's disease. And that having a neurologist, and especially a movement disorders fellowship trained neurologist, is critical for the treatment of that patient. And so even if your neurologist is doing a wonderful job, it doesn't hurt to see a movement disorder fellowship trained neurologist at least once. And then that person can tell you yes, no, or wait a little longer.
Good. And Scott, we've got about 15 seconds left. You have the final word.
Okay. I wouldn't have been on this show a year ago because I wouldn't have had this surgery. But 50 years from now, I'll be touting how great this surgery is. So if you qualify for this surgery, please consider having this surgery. It'll change your life.
All right. I want to thank Dr. Roger Smith, Dr. Georgia Lee, and Scott Boudreau for the education and information they've provided tonight, and for Scott in particular for sharing his story, and for their work, in this case everyone's work in the Ochsner Health System. To make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at this number. It's a number set up just for viewers of this program, 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Our thanks again to tonight's guests. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, WLAE.
Hello Health on LAE has been presented by the Ochsner Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.